Dr. Patrick Hanaway with us. His bio's on the next slide, and he will tell you that you can read that for yourself. Um, what I would like to say is that Dr. Hanaway and I have worked together and been friends for over 16 years now. I am thrilled to be back on the virtual stage with him. We kicked off our days doing webinars with me sitting in the closet and him being over in his office way long time ago. His wife delivered my oldest, who was pediatrician for both my boys, Patrick, and his wife, Lisa. Really, truly phenomenal human beings. And I am thrilled to get to circle back and do another presentation with him. Dr. Hanaway, the floor is yours.
Thank you so much, Michelle. I just appreciate working together with you, getting the band back together again, as it were. Here's some information about me. Many of you have seen me talk or heard me speak previously. I've been involved in integrative medicine and functional medicine for quite some time, as the slide would indicate. I was the chief medical officer at Genova Diagnostics for 10 years and brought a lot of innovative testing to the marketplace, and then during that time worked with IFM as the lead teacher on the gut module that we have, focused on assimilation, and then became the chief medical education officer at IFM, where we began to focus more teaching worldwide, and had the opportunity to then lead the Cleveland Clinic Center for Functional Medicine, doing research, teaching, and clinical care at that time, and have been proud to be able to demonstrate the positive outcomes of a functional medicine approach. And so the aspect that we're going to talk about today with inFoods IBS is, and some people have actually probably even heard me say, quote, I don't think that IgG food testing really can help because it's not the food's fault. And so it was with kind of great humility and eating a little bit of crow that I began to work with Biomerica and connect to some of the thought leaders that you'll see some quotes from, but the Rome Foundation and Dr. Doug Drossman and Bill Shea at University of Michigan and Tony Lembo at the Cleveland Clinic, who have gone into a deeper understanding of actually looking at, as Michelle said, sort of a surgical approach to being able to look at food testing as it relates to IBS. And I've seen this work in clinical practice. I've seen the papers. Will highlight the lead article from the Journal of Gastroenterology in June of last year, focusing on that. But I first want to create the context from a functional medicine approach of what's going on. And so, in that functional medicine approach, we're going to look to the root cause of restoring, or rebalancing function. It's allowing the clinicians to be able to look at the genes, the environment, the lifestyle, and create personalized interventions to be able to bring balance. It's looking at the whole person, mental, emotional, spiritual, in terms of what's going on with them. Now, within a gut framework, we use an acronym called DIG IN. And DIG IN allows us to focus on digestion, intestinal permeability, the gut microbiome, immune modulation, and the enteric nervous system. In this way, this is how we begin to think about those essential functions of the gut and what we need to be able to understand the underpinning that's there. And so when we take that approach, one of the first things we do is we ask a question that one of my mentors, Dr. Sid Baker, used to ask, and he said, what do you need more of? What needs to be replaced, and what do you need less of? What needs to be removed? And we've talked about this and worked within this kind of framework of understanding what kinds of food imbalances or food sensitivities are going on. And I first want to distinguish between looking at a food allergy, a true IgE-mediated food allergy, a food sensitivity, which is often looked at through IgG testing and food intolerance. Intolerances and sensitivities are common, as we can see. So one of the difficulties when we're looking at food intolerance and food sensitivity is that it's not an immediate hypersensitivity response. It's more of a delayed response that goes on. And those symptoms may emerge anywhere, from 4 to 48 hours after the exposure that's occurred. Food intolerances may relate to chemical sensitivities that are going on, such as we may see with a histamine reaction that would be different, or a reaction to a food poisoning that's occurring, or some particular element that's in the food. Whereas food sensitivity is usually going to be an immunologically mediated, IgG mediated phenomena that's going on that leads to symptomatology. And as Michelle noted at the beginning, those symptoms may vary greatly, between different people. So as we begin to look at these aspects of food sensitivities, intolerances, and food triggers, we recognize that they can be seen with migraines. They can be seen with depression and anxiety, with IBS. What the inFoods test that I'm talking about today is really focused on where are the cut points, what are the specific foods, and where are the specific cut points that have been showed to relate to irritable bowel syndrome. And that's why it makes this a very precise tool to help with our patients with IBS. And so when we look at, we can see the idea of different kinds of physiologic effects that I mentioned. We can see the effects of foods that are going to be mechanical and neuroendocrine, the prebiotic helping the beneficial bacteria to grow, the probiotic using specific agents, and the postbiotic, the downstream metabolites of the bacteria that are present either in our gut, in our commensal flora, or from probiotics that we're taking. And they will have an effect. They will have an effect physiologically. They will also have an effect on what goes on metabolically within the gut. And we can see that through fermentation processes. We can see that through the production of postbiotics, as I mentioned. We can, such as secondary bile acids. We can see neurotransmitters. We can see various neuroimmune chemicals that are activated all at that point in time, which then will go up into the brain as we see the so-called gut-brain axis moving into the insular nucleus and the amygdala, having an effect on mood, on emotions, on energy, on hormones through the HPA axis. So there's a lot of factors that we consider there. And when we look at this functional medicine approach, we recognize that if we start to work on eating the right foods and bringing balance back to the system, that we actually decrease the symptomatic expression that's going on. Now, but when we look clinically, one of the principal tools that we have is oftentimes using something like an elimination diet. An elimination diet to remove all the possible potential triggers. And we see, many times when we do this, the patient feels better for that period of time. Although when they're adding back foods, they don't necessarily find the exact food that is causing the trigger. We've seen some of our allergy and immunology colleagues actually raising concerns about that, because people can move into a place where they sharply restrict their overall foods. And we see this also with the kind of the FODMAPs dietary approach that I'll speak about in a few minutes, where it can overly restrict the beneficial foods that people may need. We see this too with kind of broad-based IgG testing, where people will limit or eliminate huge swaths of food that has an effect on their overall diet and nutrition, especially in the prebiotic realm. That is a major issue and concern that I would like to talk about at this point in time. So what we want to do when we're looking at dietary triggers is we want them to be as highly specific to the individual as possible. That is, what is the exact food that is having an effect for this individual? And we often find that broad-based IgG food testing gives more of a shotgun view rather than that really kind of surgical strike approach. And so when we start to talk about IBS, irritable bowel syndrome, this gut-brain interaction that's going on, we find that in the United States, 40 million people have IBS by the current Rome criteria. About a third of them with constipation, a third of them with diarrhea, and a third of them with a mixed patterning that's involved. And when we look at the people, we find that they will have an outcomes measure looking at so-called PROMIS, patient report outcomes measures that are consistent physically with type 2 diabetes and are consistent from a mental emotional standpoint with major affective disorder. So this is having a huge effect on performance, on engagement with life and in the world, and a negative quality of life, included quality adjusted life years that are lost. It's the most common reason people go to GI doctors, and patients with IBS end up seeing doctors 3 times more commonly. So it's a huge problem. And yet, when we looked at especially that 1/3 subset of IBS mixed, we'll see that there's some drugs and therapies that are used for IBS with constipation and IBS with diarrhea, though I would assert not very effectively. But there are no drugs at all approved for the mixed IBS pattern, which is 13 million people. So when we start to look at these patterns, we start to say, well, what is the root cause approach of how do we think about this, and what are the influencing factors? Now, this slide is a fascinating one to me because it kind of looks at over time the progression of talking about pain and motility issues to hypersensitivity to post-infectious IBS that we saw in the late 80s and early 90s, and starting to see the inflammatory component or the low-grade inflammatory component, chronic inflammatory component that's going on. Then we started moving into looking at diets using the FODMAP diet, FODMAP, which stands for fructo oligo disaccharide, di and monosaccharides and polyols. So these are components that are present within food, primarily within various fruits and vegetables, that can cause a prebiotic, generative, fermenting, irritative effect for individuals. Although oftentimes it's only 1 or 2 of those foods, but their whole class of foods are eliminated. We see not only with celiac disease, but with gluten sensitive enteropathy, that there's probably 10 to 20% of patients who have some kinds of issues with gluten that's going on. We begin to see biomarkers like looking at exocrine pancreatic insufficiency, pancreatic elastase, or markers of calprotectin, which can be elevated with post-infectious IBS, and important to do to be able to rule out any kind of inflammatory bowel disease. But all of these aspects have been evaluated, and then looking, of course, at the microflora and some studies with things like Bifidobacter infantis 35624 that have been shown to be helpful. That's a targeted pharmacobiotic for IBS with diarrhea. So we have some agents that are out there, but ultimately, when we're looking at this, we see that there are many different mechanisms and influencing factors. But it's what we want to try to do is we want to try to get to, what is the root cause of what's going on? Is it related to a small intestinal bacterial overgrowth? Is it related to exocrine pancreatic insufficiency or post-infectious IBS? Is it a way in which the enteric nervous system is signaling the brain and the insular nucleus and the amygdala to be able to change, vagal nerve tone? Is it related to some kind of pathogenic bacteria that may be present there? No matter how we try to break that down, when we talk to the patients, almost 80% of patients will tell you there are specific foods that cause this problem. But most of the patients can't identify what specific food is the problem. So when we start looking at dietary approaches, there's often, clinically we'll start off and say, well, I'm gonna start you off gluten free. There's plenty of gluten free options at this point in time, and I'm gonna eliminate that from your diet. Clinically, I found that if I'm gonna eliminate gluten, it's often easy for me to eliminate lactose at the same time. So-called a dairy-free, gluten-free DFGF, GFDF kind of diet is a useful first pass, and it will help a percentage of people because they're common food sensitivities, but they're not the total picture. So some people will go to, as I mentioned, a complete elimination diet of many different food groups, which is a hallmark within a functional medicine kind of approach. But that is difficult for some people to do. They can't stay on it, and others they will stay on it for too long, and doesn't always help to identify what the specific triggers are. So, since the early 2000s, when the development of this, fermentable oligosaccharide, disaccharide, monosaccharides, and polyols, FODMAP, that I talked about, came forth and showed a significant decrease in reduction of symptoms, for individuals, because you're essentially removing a lot of potential foods that may cause fermentation and changes in the microbiome. That said, it can be useful for a short period of time, but when people begin to have symptoms again and they keep going back to using the FODMAP diet, they all of a sudden overly restrict the foods and have a very significant negative effect on the diversity of their gut microbiome. So we can see there's potential problems here. We see that some people will go to a low fiber diet to minimize the gut distension and stimulation and motility issues that can occur. But we also recognize that fiber is a particularly important thing for looking at overall health and well-being, for the generation of prebiotics that are necessary to be able to produce the right chemicals and to help with the diversity of the gut microbiome. In addition to that, we see that there's an increased colorectal cancer risk when people are on a low fiber diet for a prolonged period of time, as well as other forms of cancer. And then we see some other diets down there, a ketogenic diet, which is going to be 70 to 80% fat, which also has a negative effect on the gut microbiome. Great for short-term dealing with cardiometabolic syndrome and even potentially for other kinds of neurologic issues that are going on, but not a long-term diet. And so if you haven't found what the trigger is for the individual, they use these diets, they feel better for a period of time, and then they then they have symptoms again and they go back on these overly restrictive diets. It's not what we want. So how do we really target what's happening? Well, as I mentioned, there are pharmaceuticals that are available for both IBS-C, we see on top, Linzess, Isbrala agents. When we look at the overall effectiveness of those agents, after placebo, it's on the order of 5 to 14%, not big therapeutic effects. When we look at IBS-D, we can see the non-absorbable antibiotics Xifaxan. We can see Lotrinox. We see a little better effect of these, of going from about 10 to 20% effectiveness. And there's really nothing, as I noted earlier, for the mixed IBS. There's no drug treatment options that are available at all. So when we start to look at patient care options, we need more considerations. Right now, we look at low FODMAP elimination diets, which are useful, as I said, but demonstrate the drawbacks that we've talked about. It takes a long time to implement. There's significant disruption of the microbiome and can lead to orthorexia nervosa, the aspect of overly limited eating patterns. And I would say that in talking to the dietitians, I worked with nutritionists at the Cleveland Clinic Center for Functional Medicine. We estimated that nearly 1/3 of the patients that we saw had some form of orthorexia, that they over limited their eating patterns. So this is, it's a real issue that's going on there. We see the pharmaceutical options where they're expensive, there's side effect profiles, and there's really no good studies on long-term use of those agents. When we look at the functional medicine approach that I've used successfully for the past 25 years and have written about it extensively, we see that there is symptomatic relief, but it's not accepted and it's a non-specific. If you can target and figure out what this is exocrine pancreatic insufficiency or small intestinal bacterial overgrowth, that's great. Or if there's a parasite or a pathogen and you can dial it in to that degree, that's wonderful. But there are many times where we don't see a specific root cause that's driving things, and we come back to food, and we don't have great tools other than the aforementioned elimination diets and approaches that are there. So in comes inFood IBS, and that's where we see that the targeted approach that is used will help to decrease symptoms overall. So Dr. Bill Shea, who said the chief of GI at University of Michigan, and he said, food's probably the single most important factor. This is what we need to look at. 3/4 of the patients will have problems. The IBS food steps helps us to move towards a precision nutrition approach. Tony Lembo, a vice chair at the Digestive Disease Institute at the Cleveland Clinic, where I worked, says, diets need to be recommended and are recommended as first-line therapy. We have the ability to be able to dial in a specific, looking at what specific food, has improved the symptoms. And this test, the inFoods IBS test, allows us to be able to pinpoint that. The FODMAP diet is difficult to follow and overly removes foods. So the paper regarding this was published in Gastroenterology in June of 2025. This was the lead article in Gastroenterology that month. And we see the authors of this, Bill Shea, Tony Lembo, Brian Lacey at Mayo, Eamon Quigley, who's with the group at APC in Cork, sort of the leading microbiome research institute, one of the leading microbiome research institutes in the world, and Brooks Cash, who is kind of the main teacher about IBS within the American College of Gastroenterology. So we look at who the authors are on this, and this is what got my attention, is that when these are people who I would say, and I've talked to them, I've said that IgG testing doesn't make a difference and it's not the food's fault, and they said we've said that also. But when they went in and they did the analysis of being able to look at comparing people, whether with IBS-C, IBS-D, or IBS-M, and they did it in a true experimental process of a randomized controlled trial with a sham diet. And the sham diet was not a sham diet where what we saw with tools of IgG food testing that were done in the UK in 2003. They used a sham diet where they gave everybody milk and gluten and lots of irritants, and they felt worse. So in the sham diet, they sort of stacked the deck to make the intervention diet, the experimental diet, look better. In this case, that is not what happened. So they would for example, if the inFoods test was positive for orange and walnut, we'll talk about the 18 different foods that are evaluated here. In the sham diet, they would eliminate grapefruit and cane sugar instead of orange and walnut. So they work to parallel removing similar things, and they didn't add in lots of other foods that could be potential irritants. And they went through the time frame. And what they found was that in the IgG guided food diet using the inFoods testing, is they had about a 60% response versus a 42% response in the sham diet. Now, you may look at that and say, huh, that's 42% seems pretty high. But we find is that within IBS, there is a fairly strong placebo effect that goes on. So overall, we saw a 30% reduction in abdominal pain, which is a key indicator from the FDA. When we start looking at the actual results, when we find the 60% reduction in abdominal pain, here we're looking at both patients with IBS-D, IBS-C, and IBS-M, and we see that on the inFoods diet, the green line, that there continues to be a decrease that goes on over that 8-week period of time. So as we begin to look at and evaluate the inFoods test, we'll see the lab report, beginning of it over on the right, where it identifies what are the positive foods, in this case, rye, cow's milk, cocoa, and orange, and what are the negative foods that are there. So it targets for a specific personalized elimination of the trigger foods. As we look to the results themselves, what we're looking for are these overall number of foods. And so we see these 18 foods that are present here. And when I looked at this, I thought, what I'm interested to know is, out of these 18 foods, if 75% of them are related to corn and egg and gluten and wheat and cow's milk. Well, those are the 4 things that I would be eliminating anyways. So I'm going to get my beneficial effect. But that's actually not how the data fell out. And so we see that there are a number of patients who will have a reactive response to orange or honey or cabbage or cane sugar or cocoa. It's not the typical things that we would put in the top 5, because those top 5 that we've talked about from a functional medicine perspective have all been related to IgE-mediated food allergies. It doesn't confer to IgG sensitivity that truly causes symptoms for the individual. So the beauty of the IBS inFood test is that it gives us clear cut points, positive, negative. Not you should eat a little bit of less of this. Whereas we see in IgG food testing in the shotgun patterning, where there's an array of saying from low to high, and you never know where the cut point's supposed to be, because it depends upon how immunologically compromised the individual is and how much food they've been exposed to of that particular type in terms of what's happening with their IgG reactivity. So we saw those results overall, but what I want to highlight here is that when we actually look at the overall response of the mixed IBS patients, we see a 36% improvement overall. Right? Notice that the difference, when we include the IBS-D patients, is not as great. So we don't see as much benefit in IBS-D. We see some, but we see a huge benefit in mixed IBS. And we also see a very significant, 31% improvement in IBS-C. So for me, in my patients with constipation, this becomes the first thing I think about, is what are the specific foods that I need to be looking at and considering. When we look at overall pain and bloating, we can see the improvements in bloating in the turquoise color line, and improvements in pain in the red line. And we see significant decreases that parallel each other through the process. And so these were patients who had more than 30% reduction in abdominal pain and bloating. Now, when we start to look at individual cases and we look at what their overall response is over time, we can begin to see, has the patient reintroduced a food either wittingly or unwittingly in the process. So as we see in the process of this particular patient here, patient AU, we see that at in the fifth week, they reintroduced the food that was causing the problem. They had a significant increase in their pain and bloating during that period of time. They removed the food again, and they found the beneficial effects overall re-emerging at that point in time. So it can actually be used. We can look at the patient's clinical symptoms and determine, are you using a have you reintroduced foods, or is there some way in which that food has been reintroduced that you're not aware of? We can also see that by looking at overall well-being, as we see in the case here, where there's a proxy of the patient report outcome measures of overall well-being and this decrease in well-being at week 6. So these patient examples are telling us, they're showing us when there's non-adherence to the diet that brings back pain and bloating and reduced well-being. This is, a clear one where, the patient was like, I'm doing great. I don't, I'm at 100% adherence. I don't need to continue doing this. They stopped the diet and they had a complete shift in their overall symptom patterns that was going on: pain, bloating, well-being. So when we start to look at the idea, who are the best patients to be able to use this inFood test for? Do I just use an elimination diet and see if that works? Do I use a shotgun IgG testing, or do I look to have to target my patients? So when we know that diet is going to have an impact on 70 to 80% of the patients who have IBS, who meet those Rome criteria. We know that adverse foods are going to be having an effect 70 to 80% of the times. We know that the therapies are not that great. So we may look to new patients, or we look at chronic IBS patients. In a new patient with IBS, I'm going to actually want to make sure that they don't have some form of parasites or exocrine pancreatic insufficiency or significantly elevated calprotectin level. But once I've ruled that out, then I want to go to say, well, let's look at a food first approach. And with my chronic IBS patients, where I've already ruled out those significant other potential root causes, I'm going to go right away to, helping with the inFoods IBS test to understand what's underneath this. So when we look at the assay and the cut points, the biggest difference here is that we're now looking at not only a precise number of foods. In the process of the development of this technology, they looked at 90 different commonly consumed foods, the kinds of things that we would see in a broad IgG panel. And then they looked at those and they said, well, which foods are actually show an increased IgG in when I compare IBS patients and non-IBS patients. And then they did that and looked at, well, what's the false discovery rate? What is the rate where we make an assumption that it's a food and that's incorrect. And with that, they were able to find 18 foods that from a precise aspect had an effect on IBS. And so what we can see is if we look at the non-IBS patients for food A or for food B, in kind of the top part of the panels, we can see what would be essentially like a normal distribution that goes on. But when we start to look at the IBS patients, as particularly noted in food A, we see that there are a lot more patients who have symptoms that are going on in terms of that diagnosis of IBS and the symptomatology, who have an elevation there. So that actually that defines the cut point for the overall process. So, they use the help of the Rome Foundation to ensure confidence in the results that are present here. So then, as we move forward, we see that now we have cut points with a 95% confidence interval that are specific to IBS. Well, what this means is we'll do these same foods and these same cut points apply to migraines or depression or any other disease? No. There will be different foods with different cut points that will be used. Can I use my IgG testing and just look at these 18 foods and say, well, are they positive or negative? Well, the problem with IgG tested with standard IgG testing is it doesn't define what the cut points are. And so we don't know those cut points. And that's the precision of the IBS in food testing. So it provides a personalized treatment approach and recommendation for the individual. So, if you're interested in this, I have some time to be able to listen to questions and answer, anything that comes up for you from the talk that I've given so far. But if you want to use this in your own practice, we can easily integrate it there. And the thing that I like about it is that, not only is there, can you use a blood sample, but you can also simply do a at-home pinprick. You can do it in your office with a pinprick and send it in, or you can a finger stick, or you can have patients do that at home. So in my practice, where I see people both on site and virtually, having the kit be sent to their home and be able to do the at-home self-collection makes my life much, much easier and my staff's life much easier in the process of being able to do that. And so, if you do it in office, you have the kits there, you've paid for them, they pay you, and it works like that. But if you want to do it at home, which is what I do, I have the patients pay for the kit, they get it, I get the results back, they come back to me. And they come with these rather, simple and clear lab results. Red foods, are positive and should be avoided. There's no low, medium, or high values because there's clear cut points. It's either positive or it's negative. Now, the average result that we see with patients who have IBS, who are doing this testing, is that they have 4 positive results. That's the average that we see there. Now, so you can see that if someone is doing a dietary approach with a FODMAP, for example, and they get rid of a whole bunch of different foods, but they add one of them back that from the IBS in food test would be positive, they would begin to have symptoms again. So they tend to be overly dramatic or overly restrictive in the foods that they eat, which, as I said earlier, has a significant negative effect on the diversity of the gut microbiome and thus overall health and well-being. So the results are very clear. And then there's dietary guidance to be able to indicate like where you might get exposed to honey, where you might get exposed to orange. It's not always simple and clear. So we have educational tools to be able to help the practitioners along the way. And then we have a way of being able to help them to monitor, to find the trigger foods in their favorite meals, stick to that elimination of those foods, which helps to improve compliance overall and helps the providers in the process. So we can see here that, if you're interested in setting up a new account, working to be able to do this, working with Mosaic and inFoods to be able to get these kinds of results and be able to integrate that. You can sign up as a provider, and the team at Mosaic can help you in the specific process of going through the pricing and being able to bring that into your practice. So I have appreciated taking the time to be able to talk with you and you taking the time to listen to me. I would say, overall, as a clinician, this new finding was a surprise to me clinically, and it's helped to questioned some of my assumptions, but also helped my patients to be able to feel better. So this is a great opportunity for being able to learn and share, and like to see what kinds of questions arise at this point in time. I guess there have been some things coming into the chat, and
Yes.
Michelle, I'll follow your lead on where we want to go. If we need to, look back at a slide, if there's a specific
Mhm.
question, I'm glad to do that as well.
Yeah. So first of all, thank you, Dr. Hanaway. It was a phenomenal presentation as expected. Um, I'll start with the question that always comes up when we talk about IgG testing, which is, do they need to have eaten the food?
Well, the actually the answer is yes. I mean, they're not going to have an immunologic reaction if they haven't been exposed to the food. So we can see this more classically with like celiac testing, where we're doing um, IgG testing to be able to look at, TTG. We look at IgA and we look at IgG to, uh, tissue transglutaminase or deamidate gliadin protein, DGP. You have to have been exposed to it. And so if in the foods that are here, if there are foods that someone doesn't eat at all, then they're not going to test positive. But if they've got IBS and they're not eating those foods, it's kind of a moot point, because that food's not one of the foods that they're eating and they're still having symptoms. Now, it is possible that someone could have eliminated something that they don't like, and they see that as a normal negative test, and then they add it back and they get symptoms again. That is entirely possible. But in general, the patients who have IBS are having a persistence of symptoms, and that's what's going on.
Yeah. I always remind people the basic physiology. It takes 4 days for IgGs to form, and their half life is roughly 21, 25 days. And so that's
Mm-hmm.
kind of where you're in that ballpark of people eating the food. There were a lot of questions and a lot of people brought up, but my patient is already on a plant based diet, but my patient is already vegan. Um, and I thought that was a really great opportunity to maybe repeat something you did say, but maybe dive in a little bit more deeply to the foods that are tested on this test and the foods that were shown to correlate with clinical symptoms in IBS patients. And you and I had a brief conversation around being somewhat surprised by those.
I'm sorry, I was
By the
distracted for a moment. By which specific foods were
by the
identified?
foods that are actually on the inFoods IBS test. They're not necessarily the ones that you would think about from your standard, elimination diet per se.
Right. So when we kind of look at a standard elimination diet, we're going to say, okay, stop corn, eggs, um, wheat, dairy, maybe rye and soybean, because those are the things that are going to be that the most IgE hypersensitivity reaction is to. But then when we start looking at other foods like oat or grapefruit, lemon, pineapple, cabbage, walnut, cane sugar, cocoa, black tea, honey, orange. Like when I looked at those, I thought, really? I would never guess those things. I would never even necessarily include all of those in my restrictive elimination diet. We've used different names: a reset diet, standard elimination protocol, and I didn't limit those things. I didn't limit, pineapple and lemon and grapefruit from those aspects. Walnuts. I would limit sugar. I don't remember limiting black tea or cocoa. So almost half of the things that are defined through the IBS in food test to be able to show a relationship. And recall, I said that on average, 4 of these are present, for each of the patients that are there. So, you know, even using I'll call it the shotgun IgG testing, or using an elimination diet, I'm missing some of the things that the IBS in food test is showing are part and parcel of the triggers that are present for people.
Absolutely. And there were for me, it was incredibly interesting. Similar to what you said, I don't tend to think about pulling pineapple. In fact, I use pineapple because it has digestive enzymes in it and it helps people break their food down. So, it was very eye opening for me when I saw the 18 foods that were included on this particular test and in that study. The other question that we've gotten several times, voiced in slightly different ways, but fundamentally is where in your test treat strategy do you use this particular test? So as it relates to stool testing and as it relates to zonulin and as it relates to, all of the tests we have in our arsenal, where in that pathway for a patient does this test fit in for you?
Depends on if they're new or chronic patient.
Mm-hmm.
So it's unfortunate. I sometimes laugh. I very rarely see someone with just IBS coming in as a new patient these days. It happens every once in a while, and I'm like, okay, I got this. I can handle this. But let's say it's someone who's got multiple other things going on, but they've got IBS as well. What I'm going to do is, I am going to make sure that there's no exocrine pancreatic insufficiency. I'm going to look at a pancreatic elastase. I'm going to make sure that there's not an inflammatory process, that I'm effectively ruling them out from needing to go see a GI doctor to get scoped. I want to see a calprotectin that's below 120. And if it's a little higher than that, I may work to bring that down with an anti-inflammatory. If it's above 250, I'm going to refer them automatically. I'm going to look at those kinds of things. I'm going to look at are there parasites that are present there that need to be treated. But once I've done that and I've treated that, or it's a negative finding, then I'm going to say, well, we got to look at a food first approach to what's going on. Now, what my practice has actually evolved in a way. So that's kind of probably the way I would approach it even 5 years ago. Now I'm doing less stool testing, and I'm going into a food first approach right away and want to see what's happening. I have used an elimination diet to try to get at that, but this new test has said to me, well, maybe I need to do this first and be able to see, is this a trigger that's happening here, and can I get rid of it first, because it's going to give me my biggest bang for my buck.
Have you seen patients be able to reintroduce a food, or is this kind of one of those, typically with food sensitivities, with IgGs, they're not like IgEs where you're pulling it for good, forever after, right? IgGs are you pull it, you heal it, and the expectation is that they can rotate it back in, perhaps paying attention to, don't eat all the cheese in the world. But is that something you find with this or no?
I've been looking at and working with this test for about a little over a year now. And so I have not, the patients who I've seen, they don't want to go back on the food. It's like they're resistant to it. And so I don't push it, in terms of the overall improvement of the lining of the gut. My big worldview is that the reason why we're seeing this reactivity to foods is more because of changes in the gut microbiome and the education of the immune system, and coupled with varying degrees of intestinal permeability that are happening there. We see from more recent data from the use of confocal laser and endoscopy that we can actually visualize when certain foods like gluten are going to increase the permeability that's going on paracellularly. Paracellularly. So that is, I think, the big picture. And unless and until we're able to fundamentally change the overall nature of the gut microbiome, I think if you add that food back, you're going to have the irritation happening again. So I tend to treat it more as a long-term issue. And I would be very judicious in adding foods back, to where I would do, if I were to add foods back, I would not do it more than once or twice a week, and then see how the patient does from a symptomatic basis, looking at the pain and bloating and overall wellness scores that we saw from the paper.
Excellent. And there were several questions around all of the different versions of IBS and using this particular test. So IBS M versus C versus D.
Well, I think the data on mixed and on constipation is super clear. And one of the big things that was seen at DDW is, I think the longer I've been in practice, the more I've seen how much chronic idiopathic constipation is an issue for people. And, so this is a really great tool for being able to look at that. So I kind of stepped back, and when I first looked at the data, I said, okay, I'm going to use this in my patients with IBS-C or with chronic idiopathic constipation and see what's going to happen here. And I can think of one patient in particular who has had a constipation issue for a long period of time, and it's like I've you know I have a great diet. I don't do these things, and we ended up, I said, I think you should do the test. I think you should do the test. I think you should do the test. You can do it at home, you know, person finally does the test and they find that they had, you just pointed to, they had an issue with pineapple and they were eating pineapple all the time, and they didn't view that that was any kind of issue. And they began to have significant improvements in their constipation because they took pineapple out of their diet. And, I just kind of shook my head. It's like, I never would have guessed that, but I have a test that I'm not guessing anymore. It's telling me what the specific foods are. And this is going to have the opportunity to help, 60% of your patients. Not going to be 100%. It's not going to be every time. But having a test that helps to define which foods are going to help 60+% of the patients, it's huge, especially in that mixed and IBS-C population.
And to piggyback on that, there are so many patients who, they've done the scoping, they've done the stool test, they've done all of those things, but they're all within normal limits, but they still have IBS symptoms, right? But they haven't gotten the diagnosis. So maybe they have one or two, but they don't fit all of the Rome 4 criteria. Would you still consider this in that patient population?
Yeah, recall that the Rome criteria are a research criteria that have been developed. So if I have someone who's got, bloating that's going on, for 3 over the last 6 months period of time and or abdominal pain, they don't have to meet all the criteria. I'm using that as a clinical idea. I'm not doing research to be able to define. It's also a thing because of the way in which the criteria are written for symptoms of the last 3 to 6 months, is that like if you got someone and you get rid of their symptoms completely for 3 months period of time, but they had them for 3 months before that, you haven't actually gotten rid of the IBS diagnosis. It takes a longer period of time. So what I care about is the improvement in overall symptomatology. I'm less focused on meeting the Rome criteria.
Excellent. Let's see. I'm going to ask you another question while I share a couple slides because we've had some people asking about how do you order and that kind of thing. So I'm going to pull that back up.
Yeah, and I think there were a couple slides at the end that I skipped past as well.
Yeah, no, you're good. You're good. We've had many questions about SIBO, and because there's overlap with symptomology, of course, and addressing SIBO in your IBS patients, how it relates to this particular test and how you might, the word triage is what comes to mind, but that's not necessarily what I mean. Like, what's the order that you're thinking?
Mm-hmm. So, it's a fascinating thing as one's clinically involved for a long period of time. So it's 25 years ago, I first started looking at learning Pimentel's research, looking at small intestinal bacterial overgrowth and the use of the non-absorbable antibiotic, rifaximin or Xifaxan. And I thought, oh, this is great. This is, an incredible tool. And it was an incredible tool. But then what I found was as people started to use that, their symptoms would go away. They would shift the distribution of the gut microbiome. The fermenters would go away. They would have an improvement in what was happening, and then they would continue on their same diet and then they would go back and have problems again, and they would get put on rifaximin again. And I started seeing papers. It's like, yeah, you can use it. We use this in patients, 7 times in a year, and there was no, sort of tachyphylaxis to it. There was no resistance patterning. And I thought, well, there might not be resistance patterning, but if you got to treat someone 7 times in a year for SIBO, you've not actually gotten to the underlying aspect of what's causing. And so that's where we see the distribution of the microbiome and the various fermenters that are there. And how do we get at that? I don't think that an antibiotic, or for that matter, an aggressive antimicrobial approach, such as Jerry Mullen put together, is necessarily the answer. It can be a useful tool for people to be able to improve symptomatology. But in the patients that I've had with SIBO, we have to get to what's causing that in the first place, and how do we modify or shift the distribution of their microbiome, and how do we deal with the foods that may be causing problems in the first place. And also, have we dealt with permeability? Have we dealt with immune upregulation that's happening? That's where the value of the functional medicine approach is, because it's going to look at all of those aspects that are going on. So in the setting of quote unquote IBS, the subset of patients who have SIBO, some of them are going to get benefit from the food first approach that we're taking here, because it's those foods that are causing an irritation that's going on, whether it's a fermentation process leading to bloating and pain, is not necessarily clear of the mechanism of how is pineapple and orange having an impact as a prebiotic food on the overall distribution. The sense is that it's related to its fiber and its prebiotic effect that's causing a particular subset of fermentated bacteria to be able to grow, that is causing pain for that individual at that point in time. But that's actually a theory at this point in time, in terms of what is the mechanism through which these individual foods are having an effect on ABS. And as a clinician, as a researcher, I'm curious about that. But as a clinician, I don't really care. Patient feels better, and that's what I'm focused on.
I appreciate that answer. It's the practitioner in me is often out of sync with the data geek in me.